I met Dr. David Berg, I don't know, maybe about 7 or 8 months ago, and it took me at least a full business day sitting down with him. He was kind of telling that story in a lot of different ways, and boy, did that resonate with me. So I'm glad we were able to get him here to share that with us. Let's keep moving on. Raise your hand if you could, raise your hand if I took out a map of the United States, okay, and I said Nacogdoches, Texas, point to it, and you have 100% confidence you can point to it. 1, 2, okay, maybe about 1/10 or well. So Dr. Jeremy Smith is from Nacogdoches, Texas. He became a hit client maybe about, like when we were in our very early days too. We both kind of started together, and you know, he's got his story that he'll talk about. But we, you know, I just kind of kept him in my periphery over the last 3 or 4 years, and he kind of kept getting bigger and bigger, and you know, wasn't quite sure what was going on, but it was pretty intriguing. And then I had some meetings in Houston, and I figured, you know what, I've never been to Nacogdoches, Texas. I don't even know where it is either, but I'm going to find it in a map. I'm going to point my car in that direction. I want to go see these guys and see what they're up to. And spent a day with Dr. Smith, and walked away going, wow, I mean, we work with the most sophisticated direct primary care organizations in the country, and I think the most sophisticated direct primary care is actually happening in Nacogdoches, Texas. And I honestly believe the stuff that he's been pioneering is very much reflective of that. So I said, Jeremy, we got to get you out of Nacogdoches. We got to get you to San Francisco, and you got to teach people what you're doing down there. So with that, Dr. Jeremy Smith.
That intro was amazing. Thank you very much. I'm honored to be here. Thank you to Hint. Thank you to our partners. A lot of them that are in this room. I was brought over here to tell you a little story, and that's what I intend to do. My name is Dr. Jeremy Smith. I'm from North Texas. That's way different from East Texas, where I live now. And we do have a map later to teach you where Nacogdoches is. First, you got to have a mission. You got to have a statement and a vision. And I refined this recently, and it speaks to the doctor side and enabling doctors to accomplish this mission. And with guidance from our creed, we will service a population in all aspects of health while restoring value to the purchasers of healthcare, meanwhile salvaging the honor, trust, dignity, and the art form that we practice by resurrecting the spirit of the doctor-patient relationship. The creed that's based on is what I think has to be central to direct primary care offering and patient care in general. What was wrong with fee-for-service is time. Time's the most valuable thing we have with patients. You spend enough of it with them, they will tell you what's wrong. Our job gets very easy. The fee-for-service system has waxed that away from us. And so putting time back in on purpose by decreasing volumes, taking the burden and the workload, nothing to do with patient care, off the doctors is key. Another part of the creed is access. You've heard it today, and I agree entirely. Patients have to have access. So what we've done is we use Spruce app. We've put literally our presence on their phone, and that's a wonderful way to get access. If it's HIPAA compliant, we have found it and tried it, and we have any access we can get to a patient, whether it's a widget, 800 number, an app. The guidance that patients need aren't just the doctoring. I tell patients the doctor part is easy. It's actually boring. I've been doing this for 12 years. It's knowing what the patient needs is the easy part. Knowing how to get the patient what they need, their orders, their MRIs, their labs, they don't know how to do that. Sending patients out of your office unguided is sending them to peril. So deliver the patient through all those steps. That's the London tube system. And that's what patient access looks like, they do not know where to go. And if you just let them off, they're going to end up at the Chelsea Stadium instead of the Arsenal Stadium. Economy. For direct primary care doctors, if we are not economists, we're not going to impact anything. We have to save money. There are several ways to do that. We teach our partners how to do that. We take those dollars back to the patient and the people paying for health care, which are employers in this country. So having the doctor be the one to shop for service, that's key. There's no one better at it than the physician. If I think a patient needs solution A and I found out that's really hard to buy right now, I'm the only one that knows there's 2 or 3 other solutions that would work just fine. And if I'm not the guy making that decision, then we're going to lose some opportunities. So cash. I'm hoping they can pull this up. I love this clip. It illustrates a little quote about cash. It's just 30 seconds. Bear with us. While they're working on that, I'll advance. And that clip will fit anywhere. And capitation's the other thing. I think just getting completely away from fee-for-service is going to be absolutely key. I've lost control of this thing, guys. I could do my best Steve Martin impersonation. We can just skip it. Moving out of that, let me go into the timeline. This is, if you've ever seen A Beautiful Mind, this is my slide for that. So our story, my story, that was me. That's all of you guys. That's those of us that have gone into DPC, we were there. For those of you who haven't made that leap yet, which I'm hoping to reach out to, that's you. That's all the stuff that you've heard about and the frustration. So there I was, that guy screaming and upset, and that's where Nacogdoches, Texas is. The only thing most of you might know, that's Clint Dempsey. That's where he's from, Captain America. So I quit the fee-for-service world. I started MyMD Select. That's my shingle. That's my direct primary care practice. When I started it, I had no guidance, no tools, no support. It was a pure leap of faith. I didn't transition gently. I jumped from fee-for-service straight out into the DPC world and figured, well, that ought to work. Well, I think the 3 to 5 year estimate to get full doing what I was doing was probably a good guess. Well, that gave me a lot of time to read and a lot of time to invent things. So I thought, since employers are paying for most of healthcare, why don't I make some proposition value pitches to these guys? There just wasn't a product out there. So I started, and I approached a women's shelter board there in Nacogdoches, and I told them what I did, told them what it cost. They couldn't afford a real health plan, what they called a real health plan. They were a nonprofit. And after the meeting, they loved what I did. The next week, I called to find out, hey, what do you think? Well, no, we're going to go with an ACA-compliant health plan, which yours wasn't, and a bunch of terms I'd never heard of. And this is interesting. I called the broker, and I said, hey, what is it that you sold them for that price point? Because it can't have much. And when he told me what was in it, there was nothing. It met the minimum requirements of the law, and these folks still did not have health care. So I spent a year developing with partners ACA-compliant health plans where we started over. We said, look, what I'm doing works really well. What the industry's having to sell, these minimal essential coverage plans, is horrible. The TPAs selling them don't like them. The employers don't like them. The employees don't like them. So I said, let's do this. Let's take what I do. Surely I can produce enough value to warrant my presence on the plan. And then let's wrap it into starting with that and then work our way up in richness of plans. Went back to the crisis center. The next year, they jumped on our plan. That was our first employer of substance. And it was awesome. It was working great. They were able to afford it. They went self-funded. We created savings beyond way beyond what we were charging them. And since then, they've just continuously added benefits to their health plan. Well, word got out. It's a small town there. And next thing you know, we had several more employers. And the next thing you know, we had several more employers. This is about a 2-year stretch. And then, it started getting out of hand. Our individual patients were growing as well. So we kind of had this issue and a problem. We didn't have enough labor to get things done. So at that time, we started reaching out. We found partners in the industry, great guys that were mission-minded, could easily take over health plans. We had patients in their areas. We taught them the basics of how the self-funded health plans work, all the pieces, both on the fixed and variable cost side, how they were structured. We gave them patients +1, and that +1 is the health plan. You got to think of a health plan as a living entity, and if you don't understand the anatomy of how they work, you need to learn. Because if you're just treating patients and you're not conscious of a health plan, which again is an entity, you will kill it. So we started working with DPC docs, borrowing their ideas, showing them our ideas, and what that illustrated to us after building more and more was there was not a full understanding of how to run those health plans from those docs that didn't walk through the development of it. So what we did was we thought, well, let's define that. Let's define what the DPC doc knows and then what the rest is on the administrative health plan. How do you integrate with partners? How do you put data together? How do you build relationships with all the people that you have to get employer health plans written? So we do have partners in DPC, employers. We communicate with third-party administrators, hospitals, facilities, stop-loss carriers, sales. These are complicated things. One of our first partners was Hint, great platform. We picked up a partnership that was essential, Entrust. It's a TPA out of Houston. These are disruptors in the market. They were wonderful. They helped us start with the entire scope of health plans, from the cheapest benefit plans all the way up to the richest that make the major medical health plans offered by the big box companies look like a joke. Spruce, PBMs, EMRs, hospital systems, on and on. This got complicated, and the glue to hold all this together was what we developed outside of the DPC shingle that I had to the MyMD Connect, which is this new company that's trying to get these health plans in the hands of DPC docs. So what is it if you're a DPC doc? What do you need? How do you get your services in the hands of an employer? Well, this is what we did. We came up with product. If you don't have product, it gets very hard. To define what the essentials that we need, these products need to be integrated plans. They do not need to be bolted on afterthoughts. That's not going to work. We integrate directly from the direct primary care doctor. We build the plan around that. The administrator's not the most important. The PBM's not the most important. The doctor is the most important part of this equation. So all of our plans start with him. They need to be ACA compliant. They need to be built into an ERISA benefit plan. The mechanisms that are out there outside of that I have talked to the IRS. It's not going to work. You got to go through a legitimate health plan. They're also just not bolted on. I mean, these things are sexy, and in Nacogdoches, they probably work fine. But you bolt on a DPC to a big box health plan, it's just not going to be there at renewal. You need to integrate it, again, central off the DPC to the pharmacy benefit management, the stop-loss carriers, the plan designers, the third-party administrators, and all the other minor vendors. If you don't have a relationship with those guys and you're the doctor quarterbacking the plan, you're not going to be effective. We got to have a product that's local enough to get the home turf advantage of the individual DPC doctor's talents. Everybody has their hometown where they live. Everybody knows everybody. You've got your own network of specialists. You know where the cheap MRIs are. You know how to get lab done. Those are the talents we got to capture. While saying that, we also have to be uniform enough to have a product that we can go to market anywhere that your practices are. And we have to produce results. So what are the things that you can build into a health plan from least to most cost? Well, assuming we have a DPC doc, which all of our plans are doing, you lay in generic drugs, PCP, specialists, other doctors. We don't want to disrupt some of those relationships that are out there. Labs, branded, imaging, low-level, high-level imaging. And then you get into ER, outpatient, inpatient, and specialty drugs. I thought about actually dropping off the slide over there. Those are horribly expensive. So you got to come up with ways to address each and every one of these. Find out what the employer can afford. Find out even within an employer. Maybe there's two segments. Maybe there are people that can afford the high major medical, and the rest can get on a plan that we can lay in as many things as people can afford. So we design based on the needs of the employer. What are the essentials? These need to be direct primary care only. They don't, I know our industry is going to be approached and mimicked. And so Batesian mimicry, I'm a zoologist before a doctor. Batesian mimicry is good examples. It's when you have a very effective animal out there, and then you have one that's less effective. In these cases, it's poison. And that less effective doesn't do all the work, looks a lot like him and manifests himself and tries to sell himself as what he's mimicking. I think that the DPC, it's hashtag me too. Fast passes, my patients get in first in a fee-for-service clinic, telemedicine. These things are not going to work. They're not going to produce the results. So how do we prove our worth? Data. Data, doctors should hate data. I hate data. But if we can make it automatic, meaning if the doctor creates a note and it's non-burdensome and we can capture the data on the back end, which we're doing, it works out fine. And then what do you track? You got to track useful data. We try to prove value to our employers. So we're looking at fee-for-service equivalents for services performed. So when our doctors do things, they notate a medical note, we capture that data, and we accumulate them for the end of the year so that when we go to renewal, we can show them how much we have done versus what they've paid. So not just industry metrics. Some of these things people are measuring are laughable and ridiculous. And when brokers ask me about them, I understand a lot about the broker at that point. I'm like, oh, what's your trend on some of them? Yeah. So results. We look at results. We look at data a lot. Our EMR, we can export interaction data across all of our docs. And so every month we're looking at this at least in live format. So the 2.14 million as of last month that's the fee-for-service equivalents of what we've done in total since 2017. So a little over a month, or a year and a month. And that 1.4 million is what we got paid to do it. So that's a great ROI. We can slice this data, we do, by doctor, by employer group, plans within employer groups if they have two, so we can see what's effective and what's not. And we've got a bell curve that sits a little under 1, about 0.7, all the way up to 4. And depending on utilization and some other factors, we get great results. We can see where this is happening. We cut it by all kinds of different ways. I'm not sure gender is important, but we have that data available. I'm just going to come through these. So competitive advantage, the stakeholders are everything. Some are more important than others, but I wanted to list all of them. So patients, they're the most important stakeholder here. That's who we have to help. So they love it. When you get into the employer side, all of a sudden, you've got people that would never be able to afford you outright in your practice, and that is awesome. So individuals, they've hired you. It's a different relationship. When somebody's been given a benefit plan and they walk into your clinic and they look around and it should be nice and they're treated like everybody else in your clinic, which is not what they're used to, they are so grateful. They love their boss. I make sure and give the credit to the boss. He's put you here. Here's two DPC patients. Both of them have direct primary care doctors, and at least one of them is a direct primary care doctor. So What about the DPC doctor? That's a very important stakeholder. This is at a hint. They've got a lot of cool reporting tools. That's my growth in my non-employer patient panel. Like I said, it's fine. It was going to take a while to fill up and pay all the bills, but I have very linear growth. You can trace that off the graph and you can tell when I started. That's patient volume by employer. This is in my practice. And when we started releasing employer plans in 2015, word got out. You remember my psychedelic slide. When you look at the comparison of the two, the private patients are the dark purple. And if you remember, that was a very healthy growth curve, very linear, very sustainable, a very happy DPC doc. The employer patients are the ones that are elevating that even further. So this is a big amplification of your revenue streams. Employers, I could do a whole talk on the benefits the employers have. I gave them very little time here. But giving a benefit to their employees that they're paying for that doesn't make them mad, I think is good enough reason for them to do this. Again, we're seeing ROI. If it's an ROI of 1, it's really, really nice and it's free to you, basically, at the end of the day. And we're returning money based on utilization that's amazing. We're tracking, and these numbers I'm giving you are just what the direct primary care clinic's doing for the employer plans. We're not even illustrating the claims reductions, which are fantastic. The pharmacy benefit reductions, which are fantastic. Our renewal rates are insane. $1 million plans, we're bringing off of Blue Cross. Most of those are going to spend a little under $600,000 for the year. So 40% is a fair number. The TPAs, well, they benefit. They get a new product. Every TPA out there is going to want a DPC product. It brings value. These are not things they're used to selling. And they love advocacy. And when you, the DPC doctor, are the spear point of advocacy, this is a dream to an administrator. They know this product's going to be around forever, and they want to be a part of it. Sellers of medical goods and services, they gain value, market, they keep clients. The same with brokers. If you can find a reformed broker, he can help you greatly. There's so many out there that have no hope. The pharmacy benefit management, Texas is like one of the last states where you can't dole out medicines in your clinic. It's very frustrating. So we have partners in the PBM industry. There are some transparent pharmacy benefit management companies out there, and we reward them with our business. And the carriers, the stop-loss carriers absolutely love us because, essentially they're overpriced risk for what we're doing and the risk that we're actually exposing. They've been watching us for 3 years. And when you can get enough data to them to move them, actuaries, which usually they like 20 years of data, they're already coming down on their rates, which is saving our employers money yet again. So I know that was a lot. I threw out a bunch on purpose. But the mission or the reason I came out here was to illustrate a story, a how to do, to give potential DPC docs faith that if you jump out there, reach out to us. We can reach out to your employers. We can put a revenue stream in your hands that will guarantee your success. The risk is a lot lower than it was when I went out. That's the main mission. That's what I want, is I want to help DPC docs. I want to help employers, and I want to help the patients. I think this is a cool tool to do it. We can teach you how to do it. We're happy to. This is a lifeline for your practice. So if you just want to take one picture of that, that's how you get a hold of me, and I'd be happy to entertain any questions. We have a few minutes. And thank you.